Before diving into the details of mechanisms, let's start with the core definition of a controlled drug delivery system or CDDS. A controlled drug delivery system is a formulation or device that delivers a drug at a predetermined rate, locally or systemically, for a specified period of time. So I have mentioned a formulation or device. It could be a tablet, a transdermal patch, an injection, or even an implant. So, a formulation or device that delivers a drug at a predetermined rate. So, predetermined rate is the key. The release rate is designed in advance based on the drug's properties and therapeutic needs. Now, locally or systemically. Local means drug acts at or near the site of administration. For example, eye drops. And systemic means drug enters the bloodstream to act throughout the body. For example, oral extended release tablets for hypertension. Now, for a specified period of time, the delivery duration is built into the system. It could be hours, days, or even months. These systems aim to maintain drug levels within a desired therapeutic window. The goal is to keep drug concentration in plasma within the therapeutic window, means above the minimum effective concentration and below the maximum safe concentration. It could be oral, transdermal, injectable, and implantable. Now that we know what a controlled drug delivery system is, let's understand why it is used. So first, improved patient compliance. Many drugs need to be taken multiple times a day. This increases the chance of missed doses. Controlled drug delivery system reduces dosing frequency, often to once a day or even less. For example, an antihypertensive controlled release tablet taken once daily instead of 3 times daily. Next, reduced side effects. In conventional dosing, high peak concentrations can trigger dose-related side effects. Controlled drug delivery system maintains steady drug levels, avoiding toxic peaks. For example, sustained release non-steroidal anti-inflammatory drugs reduce gastrointestinal irritation. Next, better drug utilization. In immediate release forms, part of the dose is often wasted due to rapid elimination before it can act. Controlled drug delivery system improves bioavailability over time, ensuring more of the drug is used effectively. Next, targeted delivery. Drug can be delivered directly to the site of action, minimizing systemic exposure. Next, consistent therapeutic effect. A stable plasma concentration keeps the drug in the therapeutic window for a prolonged period. This means fewer fluctuations in drug effect and more predictable results. Next, cost effective in the long run. While controlled release formulation may be more expensive initially, they reduce hospital visits, complications, and doses waste. Over time, this lowers total healthcare costs. We have already discussed why controlled drug delivery is needed. Now let's go one step further and look at the specific advantages this system brings to both patients and healthcare providers. So first, improved patient compliance. Fewer doses per day, less forgetting, less interruption to daily routine. This is especially important for chronic illnesses where lifelong treatment is required. For example, once daily sustained release antihypertensives instead of 3 to 4 doses. Next, consistent therapeutic levels. Controlled drug delivery system keeps plasma drug concentration within the therapeutic window for long periods. Avoids the peak and trough fluctuations common in conventional dosing. Next, reduced side effects. By preventing sharp concentration spikes above the maximum safe concentration, controlled drug delivery system minimizes toxicity. Next, targeted drug delivery. Delivers the drug directly to the site of action, reducing systemic exposure. For example, transdermal patches for local delivery in pain management. Next, enhanced drug utilization. Maintains optimal drug levels for maximum pharmacological effect. Minimizes drug wastage due to rapid clearance. Next, minimized dosing frequency. Long-acting formulation can replace multiple daily doses, improves lifestyle convenience and adherence. Next, better control of chronic conditions. Chronic diseases like diabetes, hypertension, and epilepsy require steady therapeutic control. So, controlled drug delivery system helps maintain long-term stability in these conditions. Reduce or reduction in overall healthcare costs. Fewer hospital visits, reduced emergency, and less need for high doses. In the long run, the system becomes cost effective despite higher initial formulation costs. While controlled drug delivery systems sound like the perfect solution, no technology is without limitations. Let's take an honest look at the challenges and drawbacks of controlled drug delivery system. First, high development and manufacturing cost. Formulating controlled release systems often requires specialized polymers, coatings, or nanocarriers. Complex quality control and stability testing increase costs. This is a major barrier for low-cost generic manufacturers. Next, complex formulation process requires precise control over drug release kinetics. Use of advanced techniques like microencapsulations, osmotic pumps, or biodegradable implants demands high technical expertise. Even small errors in formulation can alter the release rate. Third, limited availability for all drugs. Not every drug is suitable for controlled release. Drugs with very short half-life, very high dose requirements, or poor stability in GI fluid are often unsuitable. Next, risk of dose dumping. If the system fails, the entire drug load may release suddenly. This can lead to acute toxicity. Next, difficult to remove drug once administered. Unlike an IV drip that can be stopped, oral controlled release forms keep releasing after ingestion. This makes emergency dose adjustment difficult. Potential for system failure. Mechanical, chemical, or environmental factors can disrupt release. Transdermal patches may detach, osmotic pumps may clog, or polymer erosion rates may change. Next, patient-specific variability. Factors like GI transit time, pH, enzymatic activity affect performance. A release rate optimized for one patient may not be ideal for other. When designing a controlled drug delivery system, not every drug is a good fit. There are certain physicochemical and pharmacokinetic properties that make a drug ideal for controlled release formulations. Large doses make the dosage form bulky, difficult to swallow, and may exceed the capacity of the delivery matrix or coating. Controlled systems work best for potent drugs requiring small amounts, so dose less than 500 mg. Biological half-life between 2 to 8 hours. Drugs with too short half-life require very large doses to maintain prolonged release. Drugs with very long half-life do not need controlled release. Conventional dosing works fine. So 2 to 8 hours is optimal for maintaining steady plasma levels. Good aqueous solubility and stability. The drug must dissolve adequately in GI fluids to be absorbed. Poorly soluble drugs may lead to erratic release profiles and reduced bioavailability. Uniform absorption throughout GIT. If the drug absorbs only in a specific region, controlled release over long transit times may be ineffective. For example, drugs with absorption window issues may need modified designs like gastroretentive systems. Large therapeutic window means range between minimum effective concentration and maximum safe concentration. Controlled release is safer when even slight variation in drug release do not cause toxicity. Next, first pass metabolism acceptable. Some drugs undergo first pass hepatic metabolism before entering systemic circulation. Controlled system should maintain plasma levels despite metabolic loss. Next, low molecular weight. Smaller molecules cross biological membranes more easily. This aids consistent absorption during extended release. And last, moderate lipid and water solubility. Balanced solubility ensures the drug can dissolve in aqueous GI fluid and permit lipid membranes. So extremely hydrophilic or lipophilic drugs often have poor absorption consistency. Not all drugs are appropriate for controlled drug delivery. Some pharmacokinetic or physicochemical properties make controlled release not only ineffective but potentially dangerous. So, unsuitable drug characteristics. First, very short or very long half-life. Very short half-life means the drug is eliminated too quickly, requiring a high loading dose to maintain prolonged release. This increases the risk of dose dumping and toxicity. And very long half-life means the drug already provides prolonged systemic levels without modification. Next, very low or very high solubility. Very low solubility means dissolution rate limits absorption, so release may be incomplete. And very high solubility means the drug dissolves too quickly. Now next, narrow therapeutic index. Small changes in plasma concentration can lead to serious toxicity. Control systems may release unevenly due to physiological variability, making them unsafe. Next, unpredictable absorption. Drugs that depend on specific pH conditions, enzymes, or localized absorption windows may fail in controlled drug delivery system because the release location and rate cannot be perfectly controlled. And second, this leads to variable bioavailability. And last, drugs requiring immediate onset of action. Controlled drug delivery system delays peak plasma levels, not suitable for acute pain relief, emergency treatment, or critical rescue medications. This requires rapid systemic availability rather than prolonged release.